Welcome to Prime Physio. This is Mahmoud Saad demonstrating one of the very common assessment sheets that we use clinically. The first bit of this assessment sheet is a common one that's always used in any other assessment sheet. Just gathering information about patient name, date of birth, functional activities, hobbies, or any other relevant information like marital status, or job, or any other relevant information that you might feel important to know about the patient. For me, functional activities and hobbies are very important to know, basically because according to patient activity level of activities and hobbies, we can set the treatment goals, and also we can understand some of the easing and the aggravating factors that might affect our treatment choices later on. Other things we need to know is severity of symptoms, how much pain the patient have. Let's say it's 1 or 2 or 10 out of 10. If the patient's symptoms is 1 or 2, that means it's quite is low severity and is not really affecting his functional activities. However, if it's 8 or 7, that means it's quite high. Irritability, how long does it take for the symptoms to start, or to start to be annoying to the patient, or to stop him from doing things. So if the patient with low back pain and the patient feel the symptoms after 5 minutes of sitting down, this means the symptoms are low irritable. But if the patient is highly irritable, if the patient symptoms start after 2 hours, that means it's has low irritability. We use these two, severity and irritability, as outcome measures. So if the patient's symptoms on day 1 was 8 out of 10 and symptoms appear after only 5 minutes of sitting down, but after 6 weeks it's only 2 out of 10 and it appears after 5 minutes of sitting down, this means the patient is improving, which is very important, encouraging factor for the patient and also for us to see if our treatment is effective or not. Nature, we're talking about nature of symptoms. For example, patient feeling pins and needles, tingling, or sharp shooting pain. This might indicate neural nature of symptoms. Patient with diffuse, dull ache, difficult to localize on the shoulder. This might indicate arthrogenic or capsular problem. Patients feel localized pain, throbbing, toothache, or dull ache sometimes, mainly with movement on the shoulder on the outer side, which mainly with abduction. This might indicate supraspinatus or mid-deltoid or myogenic origin of symptoms. So these three things are a key information that we need to know, we need to gather during our subjective examination. Easing and aggravating factors, again, very important to know. Easing factor, if the patient said, I feel the pain is much less if I lay down flat on my back, and he had neck pain. So this might indicate that the patient's symptoms are of mechanical origin, because its symptoms change with position and movement. Also might indicate that extension is a preferred direction for cervical spine, and later on in treatment we might use extension techniques or extension treatment as a home exercise program, or to apply some extension mobilization, for example. Aggravating factors, this is very important to know, again, because it might indicate the nature of the problem, either mechanical or inflammatory or others. If we know about the aggravating factors, we might encourage the patient to avoid these aggravating factors. For example, patient with cervical spine pain that always increase with a slouched or flexion posture. So it makes sense that this patient has to avoid or to keep moving his posture and avoid sitting in this position for a long time. Special questions, these are questions we ask in order to rule out any red flags or serious pathologies. Patient with lumbar spine pain, we might ask him if he has pins and needles continuously on the lower limb, if he can't control urine or bowel, because these might be a sign of coda equina. Or an old lady, for example, with shoulder pain all the time, there's night pain, no position or movement decrease her symptoms, and she has, we might need to ask her if she has a history of cancer, or might need to ask her if she been losing weight unexpectedly or with no reason recently, because this might be a sign of carcinogenic problem. 24-hour pattern, which is asking the patient about how the symptoms looks like in the morning, afternoon, and evening, and at night. So if the patient's symptoms more in the morning, but it decreases as the day progresses, so this might indicate pain of mechanical origin. This also might indicate pain with arthrogenic background, because again, when you start moving, this means there is more lubrication of the joint and tissues around, and the symptoms will get less. Again, this is just a suggestion, a hypothesis. PM, if the patient's symptoms increase at the end of the day, this also might indicate mechanical origin of the symptoms. And here, this might encourage us to look at the aggravating factors and think about what kind of aggravating factors are there that increase the patient's symptoms by the end of the day. This might be posture, might be sitting down, might be any specific position of the joint. Night pain, and here we need to think about two things when you ask the patient about the pain that he feels at night. If the patient struggles to sleep because he can't find a position that's comfortable, this might indicate a mechanical pain, because mechanical symptoms always change with position or movement. But if the patient wakes up at night because of the pain, regardless the position that he's lying on, this might indicate inflammatory origin. Again, just a hypothesis. Here is a body chart. We can point out any symptoms using arrows. So different ways to record the patient's symptoms on the body chart. This is one way of doing that. So let's say our patient has neck pain, which started 2 weeks ago. That means this is the first pain the patient felt 2 weeks ago. So we call it P1. And the type of the pain or the nature is ache, dull ache, and it's intermittent, which means it's not all the time, it's on and off, and it's 8 out of 10. Good. Now, the patient also has another type of symptoms on the arm, so we call it P2 because these symptoms started after P1, let's say 2 days or 3 days after P1. That's why we call it P2. It's intermittent, pins and needles, which might indicate neural origin of symptoms, and it's 5 out of 10. Good. So yeah, this method is very helpful because you use very little number of words in order to explain too many things about the patient's symptoms. Here, history of current problem. In this case, you need to explain any other details about the patient's symptoms. For example, here I might say cervical spine pain started 2 weeks for unknown reason, followed by pins and needles and tingling on the outer side of the left arm, and pain is increasing by time. So here I'm describing the symptoms in more details. PMH, which is past medical history, any kind of medical problems the patient had before, or any other details related to this specific problem. Once we finish with subjective examination, we can progress to the objective or physical examination. Sometimes you might end up doing too many things in your physical examination, which will be really time consuming and might indicate lack of clinical reasoning. But if you have a sound clinical reasoning, you can use the information that you get from the objective examination to be very specific on deciding what elements of objective examination you will do today. So that's why we use this system, which you call must should. So must, what elements of physical examination you must do today. For example, for this patient, cervical pain, pins and needles on the arm, a clinician might say, I must need to assess patient posture, neck range of movement, and I might do neural examination. I might do special tests for the shoulders to find out if the patient also has shoulder problem or not. So again, this will vary from between clinicians. You need to end up with what we call clinical impression. People who are really interested on direction preference might need to look for any preferred direction that has made the patient's symptoms less. The good thing about that is we can use this direction as a treatment protocol. Others might be very keen to describe the origin of the patient's symptoms, either myogenic, arthrogenic, or neurogenic. So myogenic, generally speaking, will be symptoms that increase with movement, specific towards a specific direction. Arthrogenic, this always related to end range pain or end range symptoms. Again, I'm just giving examples, but with no details. Neurogenic, this means the patient is related to a central neural problem. This means the neural tissues is irritated centrally, either at the level of the spinal cord or the nerve root, or neural peripheral, which means patient neural tissues is irritated at a peripheral level. Let's say if we talk about sciatic nerve, it is irritated at the level of the piriformis muscle, hamstring, or anywhere else on the lower limb. Here you will set your treatment protocols and try to be specific as much as you can, and try to make sure your treatment is actually reflect good understanding of the patient problem and the patient needs. Home exercise program, be careful not to give the patient too many exercises, because the research says that if you give the patient too many exercises, he will end up doing none. So make it specific, functional, and not really time consuming, so the patient can do them easily, and this will increase or maximize the patient compliance with the treatment. So this was a very quick and brief demonstration of one of a very common assessment sheets used by clinician. Again, each clinician might add or might change or might modify in order to make it more relevant or more friendly to his own assessment and treatment approach. So hopefully you find this helpful, and thank you.